bring yet another round of insightful discussions and valuable clinical perspectives from our distinguished speakers. Let's begin the proceedings and continue our shared journey of learning and collaboration.
We take great pleasure in welcoming Dr. Tahir Mahmood Hashmi, Consultant Rheumatologist at Shifa International Hospital, Islamabad, and Dr. Asher Ikhlaq Ahmed from Ziauddin Group of Hospitals, Karachi, as the chairpersons for this session. Joining them as co-chair is Dr. Aisha Mahmood Malik, a well-reputed name in her field. I'd now like to invite them to preside over this session.
To begin this session, we have with us Dr. Kallum Deshapriya, Consultant in Rheumatology at the Teaching Hospital Karapitiya, Galle, Sri Lanka. He will be delivering an intriguing talk titled Diagnostic Enigmas in Rheumatology. Please join me in welcoming him to the stage.
Good morning to everyone. It is always good to be among friends. I would like to thank Professor Ahmad Said and Professor Nigat Ahmad for inviting me to deliver this presentation today. I would rather like to, throughout this discussion, would like to engage with you all with differential diagnosis and the possibilities. This will rather be a sort of a case-based discussion rather than a very high fluent academic presentation. It's always good to be among friends. Now this was taken in Nepal when I was the immediate past president of our college, when the South Asian Rheumatology Forum, which is an informal gathering, was formed. You can recognize these three people, and your president and Professor Nigat, and you can see the lady who is holding the phone with a new gadget, the new telephone holder, right? They are not only rheumatologists, they are singers as well. And this brings me to the very fond memories of these days, some 6 years back, and when the South Asian Rheumatology Forum was formed. And this is the logo that we designed. In fact, I designed this for, I designed this logo, and it is the far-sighted wisdom of Professor Devasis Danda which made this forum a reality. Unfortunately, we missed him and we fondly remember him. So, Diagnostic Enigmas in Rheumatology. And with all due respects to my colleagues in other specialties, I, as a rheumatologist, believe that rheumatology is the most interesting and challenging clinical fine specialty. I can't think of any other specialty much more interesting and challenging than rheumatology. So you all should be proud about what you all are practicing in your clinical medicine. Rheumatological diagnostic enigmas adds to the beauty of our daily clinical practice. Why enigmas matter? Rheumatological diseases overlap with many specialties, almost all. Neurology, dermatology, hematology, nephrology, you can name any specialty and it overlaps with almost all the specialties. And these rheumatological diseases are heterogeneous in presentations. Therefore, it is difficult on the first presentation sometimes to diagnose very directly. And as a result of that, there is a tendency sometimes the diagnosis will be delayed. That is a challenge to rheumatologists. And not only that, there is a possibility that we might make incorrect diagnosis in the assessment and in clinical judgment, and when we are treating our patients this is a possibility, and these are the challenges that the rheumatologist has to face. The complex rheumatological diseases tend to be diagnostic enigmas. Why? Overlaps of common rheumatological diseases are not very uncommon. When a patient presents to you with very obvious clinical features, you tend to diagnose a disease, but when you are further questioning and examining, you will find some more physical signs and investigations, and that will make your life more complicated. Now, which one is this patient is having? So it is an overlap of common diseases, not rare diseases, common diseases is a challenge. Lack of diagnostic criteria or pathognomonic or clinical laboratory features. Our rheumatology practice is unique in that we do not have very many diagnostic criteria. We don't have pathognomonic clinical features. We don't have pathognomonic laboratory features. So we have to rely on our clinical skills and interpretation of the data very carefully. Unusual clinical features or laboratory investigations make our job more difficult. When you have a patient otherwise very straightforward and you think the diagnosis is, say, rheumatoid arthritis or SLE, and all of a sudden when you are examining or investigating, you find something very unusual investigation or a clinical feature which will not fit into the current presentation. Then you have to think very hard how to explain that. Infections and malignancies are challenges. So these are two serious conditions that the rheumatologist has to exclude in all your rheumatological diseases. The first presentation of an otherwise recurring chronic disease sometimes is a challenge. Very straightforward, but this is the first time. How to label, and you are a bit hesitant to put the label as the diagnosis. So, I mean, these are the challenges that we have to face. So, I will base my discussion on two cases. The first case is a 42-year-old female school teacher, and she is presenting with a history of persistent joint pain and swelling in all in the upper limbs, both small and large, elbows, wrists, proximal interphalangeal joints, and morning stiffness of more than 1 hour. Initial episodes were intermittent and mimicking very much like rheumatoid arthritis, and progressed to more frequent flares. Recurrent low-grade fever and fatigue during flares, painful red eye, occasional episodes of sternoclavicular joint and anterior chest wall pain. The past medical history: plantar fasciitis, was injected 2 years back by a general practitioner. According to him, it looks like that the patient has had plantar fasciitis. The patient does not have records. In our setup, we do not have digital databases, and patients carries all the clinical information on exercise books and some notes. And in this case, when a patient first confront with a general practitioner, patient generally will not have anything, only the prescription to buy the drugs. So you do not know exactly what has happened 2 years back. It is likely that the patient has had plantar fasciitis. No non-inflammatory joint diseases or connective tissue diseases in the past. And there was one episode of mild auricular pain and erythema. Patient attributed it to the caterpillar insect allergy. and which lasted in 1 or 2 days. That is 3 years back. Nothing happened after that. Examination, the patient had symmetrical inflammatory polyarthritis involving both small joints of the hands and the wrists, costochondral tenderness with tender swollen right sternoclavicular joint. This costochondral tenderness, generally it is very difficult to say whether it is costochondritis or enthesitis in spondyloarthritis. I mean, what you really get is the tenderness. You do not know what is really happening. It may be muscle pain, it may be costochondritis, it may be enthesitis. Anything is possible. No features to suggest connective tissue diseases in the current presentation. No features to suggest vasculitis. So this is the patient. So what is the diagnosis? This is what patient basically had: inflammatory type of bilateral symmetrical polyarthritis, painful red eye, auricular swelling of doubtful significance, past history of possible plantar fasciitis, costochondritis or enthesitis, sternoclavicular inflammation. Would you like to give me a differential diagnosis? What are the possibilities? What could this be? What is your first differential diagnosis? Anything is possible. I mean, come on. Just give me one diagnosis. Sorry? Spondyloarthritis. Sorry? Cogan syndrome. Anything else? Sarcoidosis. One more. Yeah, okay. So we make our differential diagnosis based on our experience in our part of the country. So it is very important when you are making a diagnosis, the rarest possible diseases in your region will be in the down of the list, top of the list, depending on the clinical features and the prevalence of the diseases. Yes, I agree with you, spondyloarthritis, and there are some features to suggest possible relapse in polychondritis. Costochondritis, sternoclavicular joint tenderness, this auricular swelling, even though the patient says that it is probably due to a caterpillar insect bite, it may be auricular chondritis. So these are the two differential diagnoses at that time. I agree with you all the other diseases mentioned are possible differential diagnosis. Right. Now this was the investigation panel. Except for very high ESR and CRP, all the other tests were basically normal. Ours is a setup where all these investigations are not readily available promptly. We have to wait for some investigations. So what is striking is very high ESR and the CRP. Now what is the diagnosis? Are we going to change our differential diagnosis based on these findings? Inflammatory type of bilateral symmetrical polyarthritis, left eye red eye, and the ophthalmological examination is a left eye anterior uveitis, auricular swelling of doubtful significance. I am still keeping it in the side. Past history of possible plantar fasciitis, costochondritis, enthesitis, and sternoclavicular inflammation, very high ESR and CRP. Right, now, what are the differences? Are we going to add more to differential diagnosis? Are we narrowing down our differential diagnosis? Can we go to a diagnosis now? No, I mean spondyloarthritis, very high ESR and CRP, yes, it is possible, but that is not the usual. Tuberculosis in our setup is something that we will always consider in most of the patients who are having ESR of more than 100. It is one of the top differential diagnosis in our setup. In this patient, there is no evidence of pulmonary involvement. This may be probably extra-articular rheumatological manifestation or extra-articular tuberculosis presenting maybe Ponson's disease. Relapsing polychondritis again, what is unusual about that is, it is said that the ESR and CRP is generally not very high in relapsing polychondritis. So when you have a patient suspected relapsing polychondritis that is with very high ESR and CRP, that is an unusual presentation. Not only that, it is a rare disease. We do not see these patients very frequently. So it goes down in the list. Could this be a paraneoplastic syndrome? So these two diseases, infections and the neoplasms, we generally include in our differential diagnosis when the ESR is very high and the clinical picture is towards that. Patient was discharged on NSAIDs. Basically, it was all right. And these were the tests that we planned. So this will take time in our setup. So patient was reviewed in the clinic in 2 weeks' time. This time presented with acute left auricular chondritis. Very acute, severe, painful swelling of the left auricle. The patient itself giving the diagnosis, not the rheumatologist who is making the diagnosis. The patient is making our life easy. So we made a clinical diagnosis of relapsing polychondritis. Unusual features of spondyloarthritis are the symmetrical polyarthritis and the upper limb predominance is unusual in this patient. Auricular chondritis and sternoclavicular joint involvement is unusual. Malignancies can present as relapsing polychondritis. So based on all this, we made a diagnosis of relapsing polychondritis as the most likely diagnosis here. So according to the McAdams criteria, the patient already fulfilling 3: auricular chondritis, non-erosive seronegative inflammatory polyarthritis, and uveitis. 3 out of 6 criteria is enough for clinical diagnosis. Unusual features of relapsing polychondritis are the enthesitis associated arthritis, very high ESR and CRP, and unilateral chondritis. It is generally said that it is bilateral, but you can get unilateral chondritis as well. So what are the differential diagnoses for this patient? Again, there are important differential diagnoses again. Now, even though we made the clinical diagnosis of relapsing polychondritis, vexas, autoinflammatory diseases, and immune checkpoint inhibitor related adverse events, that is cancer immunotherapy, can present very much like polychondritis. These are important differential diagnoses that you have to keep in your mind. Management was straightforward in our patient. Patient responded very well to glucocorticoids. The other treatment options are the colchicine, dapsone, methotrexate, TNF-alphas, and the biologicals. The case 2, a 32-year-old male with fever, fatigue, weight loss, severe joint pains, and he had painful red eye, mild hearing impairment, and he had active synovitis of the knees and ankles. So what are the differential diagnosis for this patient? Inflammatory arthritis and Coggans. Vasculitis is also a possibility. So these were the investigations that we have ordered. Further evaluation, the ophthalmologist reported that the patient is having interstitial keratitis, which is a characteristic finding that the patient should have to diagnose Cogan syndrome. Audiometry reveals bilateral sensory motor, sensory neural hearing impairment. The clinical diagnosis of Cogan syndrome was made, but the final diagnosis in our country is not possible. Genetic studies we have not attempted, and it is very difficult to get it done. We have to send it overseas. Arthritis, interstitial keratitis, sensory neural hearing impairment, and high inflammatory markers were the patient's presentation. So diagnosis of Cogan syndrome was made. Is a diagnosis by exclusion characterized by inflammation of the inner ears and the eyes, presenting with vestibular auditory dysfunction and interstitial keratitis. Typical Cogan syndrome's vestibular auditory symptoms arise within 2 years of ocular involvement. When you have exceeded 2 years, you say atypical Cogans, but typical Cogan, these should occur within 2 years. No particular biomarker. Yeah, these are the management options available. So differential diagnosis of Cogans is very wide. Walk-Koyanage harada, congenital syphilis, polyarthritis nodosa, vexas. Right. So what is my take-home message? To become an exceptional rheumatologist, broaden your clinical exposure by seeing and learning from as many patients as possible. That is the only way that you can master your study or the field of rheumatology. There is no other way. You can read the details. In this area it is not that difficult, but seeing patients and appreciating the clinical features is the most important thing. These are my references. Thank you very much.
Thank you for that enlightening presentation. Our next distinguished speaker is Professor Samina Ghaznavi, Professor of Rheumatology at South City Hospital, Karachi, Pakistan, and the immediate past president of PSR. She will be speaking on low back pain local guidelines, a rheumatology perspective. Let's welcome her to the stage.
أعوذ بالله من الشيطان الرجيم. Bismillahirrahmanirrahim. With the name of Allah, most merciful and benevolent. Nahmaduhu wa nusalli ala rasulihil kareem. Amma ba'd. Assalamu alaikum, ladies and gentlemen, and a very good morning to everybody. It is indeed an honor and a pleasure for me to be here this morning and speaking from this podium to address this august audience. Very thankful to PSR. Okay, I have about 20 minutes. Very thankful to PSR for giving me this opportunity, and congratulations to the entire Lahore team for arranging this wonderful, wonderful conference. So, I'm going to talk about a multidisciplinary perspective on low back pain management. Now, this was a presentation, rather this was a teaching aid which was prepared by one of the leading pharmaceuticals in Karachi, Getz Pharma. So they prepared these teaching guidelines to be able to educate the frontliners who are the local doctors and the GPs in our community. Because we know that low back pain is a very, very common symptom, and most of the patients, 90% of the patients everywhere, whether in the rural areas or the urban areas, land with the local doctor. So, and there can be multitude causes of low back pain, ranging from mechanical orthopedic causes to neurological causes to rheumatological causes to gynecological causes, so on and so forth. And all of them cannot be treated in a similar manner. So the local doctor, the frontliner, needs to be educated about the various causes, how to pick up the signs and symptoms, and if possible, give initial management, initial treatment. And when they have picked up certain signs, then they need to refer them to the relevant specialty. So this was the basic aim of making these guidelines. And they were made in very, very simple language, so that the local doctors are able to understand them. So as we know, the International Association of the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And the pain can be localized, affecting a specific part of the body, or it may be generalized. So it is described as soreness or discomfort in the lower back. All of this was made to educate the GPs and the local doctors. So it is a soreness or discomfort in the lower back, more precisely in the region between the rib cage and the buttocks. It can be a chronic condition with a variable course characterized by often recurrent but transient episodes of pain in the lower back. Up to 80% of people are predicted to experience lower back discomfort at some point in their lives. And this discomfort has a significant negative influence on the quality of life, productivity at work, and of course, the healthcare costs. So it was estimated that globally, 619 million people experienced low back pain in 2020, and it is predicted that the number is going to rise to about 843 million people by the year 2050. So the lifetime prevalence of pain in the general population approaches about 100% for acute pain leading to the use of analgesics. Pain accounts for more than 2/3 of causes of emergency visits, and it amounts to more than 50% patients admitted to hospitals. And we can see that the global prevalence of pain is pretty high, and this is the representation according to the various. Now, if we see the prevalence of low back pain in Pakistan, we see that maximum number of people experiencing low back pain were in the age group of about 21 to 40, to be followed by 41 to 60. So this was the major chunk of the age group, ranging from 21 to 60 years of life, which again is the most productive period of one's life. So the pain can be mechanical, non-specific, inflammatory, referred, or pain with radiculopathy. So we see that chronic back pain is one of the most common reasons for medical visits. 2/3 of the adult population suffer from low back pain at some time in their lives, and an estimated point prevalence of 33% among the office workers. Ergonomics and psychosocial factors very much contribute to low back pain, and there are no treatment guidelines present for standardization of diagnosis and treatment. So for this purpose, Getz Pharma set forth And they approached the presidents of 5 different societies. And at that time, I was the president of PSR. So they included the Pakistan Orthopedic Association, PSR, and Society for Interventional Pain Medicine, and the Pakistan Society for Neurology, and the Society for Gynae and Obs. And they contacted the presidents, who then made their own task forces in their own field. So we also made our task force, and we gathered one leading rheumatologist from every major city in Pakistan. And so this was our task force. Myself, Dr. Ahmed, Dr. Tabe Rasool, Ahmed from Lahore, Tabe Rasool from Karachi, Dr. Nazir from Quetta, and Dr. Babar Salim from Pindi. So we had representation of the entire country. And we set forth and we made these guidelines in extremely simple language. And then Getz Pharma then had them printed, published for dissemination, and they launched these guidelines in a very ceremonious manner, and the ceremony took place at their I think it was their head office, Astola, Karachi. And it was then that the hard copies of the guidelines were launched. And these are all the presidents of the 5 societies. And then they made hard copies, and I think those hard copies are available today also. Are they? Yes. And sorry? Yeah, and they will be distributed, inshallah, to all of you. So this was the manual which is printed, the low back pain guidelines. So we know that the major causes of low back pain can be rheumatological, neurological, orthopedic, etc., etc. So we are going to touch on the rheumatological causes. So we see that there's a huge burden of autoimmune diseases which goes undiagnosed in Pakistan. And the incidence of rheumatoid RA in Pakistan is about 0.5%. That of ankylosing spondylitis is 0.5%. Atopic dermatitis and severe eczema is about 6%. And psoriasis is 4%. Psoriatic arthritis is 1.8%, and ulcerative colitis is about 0.05%. So these were the major causes of low back pain that we taught to the local doctors. So we started with the psoriatic arthritis, and we explained to them that it is estimated to affect about 0.1 to 1% of general population. It is commonly associated with psoriasis, a common skin condition. The prevalence of psoriatic arthritis is influenced by genetic factors and may vary among different populations. Next, we touched upon the enthesitis-related arthritis, or the juvenile SPA. So this refers to the onset of symptoms before the age of 16 years. And the prevalence of enthesitis-related arthritis is estimated to be around 1 in 1,000 children, with a higher incidence in boys, and it represents a subgroup of spondyloarthritis that primarily affect the enthesites. So then we touched upon infective spondylitis as well, and so ankylosing spondylitis was explained to the local doctors in a very simple manner, that it is known as axial spondyloarthritis. It is an inflammatory disease that eventually causes stiffening and fusion of the vertebrae. And if the rib cage too gets affected, there may be respiratory depression. So the clinical features were taught that it has an insidious onset, accompanied with morning stiffness of a few hours duration. The pain may become persistent and bilateral, and the predominant sign here being back pain and stiffness. There may be bony tenderness in various places, and neck pain and stiffness may also come on, but this is a late manifestation. Then we touched upon the psoriatic arthritis, explaining that it is a chronic progressive inflammatory disorder characterized by osteolysis and bony proliferation, HLA-B27 associated spondyloarthropathy. It can range from mild non-destructive to severely rapid and destructive arthropathy, and usually the RA factor is negative. The clinical features again are morning stiffness, nail changes, and some joint tenderness is also there. Dactylitis is there, conjunctivitis, iritis, uveitis, etc. are also there, and distal extremity swelling with pitting edema has also been reported. Then we touched upon enthesitis-related arthritis. It is a type of arthritis that involves the joints along with the spine. So the joints involved are the hips, shoulders, knees, ankles, and it may occur in adults as well as in children, and often happens in people who are about 20 to 30 years old, and it can also be seen in the teenagers. So the clinical features again are pain, tenderness, swelling at the sites of the tendons or the ligaments, commonly affects the Achilles tendon, the plantar fascia, and persistent intermittent pain in low back. Growth may be diminished due to chronic inflammation, and eye signs are very much there. So an algorithm was made, and we taught them that patients who present with rheumatological back pain assess the following factors, and these factors were supposed to be assessed in the history, and these factors were supposed to be seen in the examination, and then relevant investigations were supposed to be done. To begin with, simply CBC, ESR, and an X-ray. And if something was found over there, then we were supposed to proceed to other investigations like HLA-B27 and MRI, etc. So, based on the diagnostic findings, they were supposed to determine the underlying condition, initiate appropriate treatment, and if they picked up signs pertaining to specialist referral, then a quick and urgent referral was supposed to be made. So this is a very interesting algorithm which says that if there is back pain of less than 3 months duration, insidious onset, age is less than 40 years, early morning stiffness is there, there is night pain, there is buttock or thigh pain, it improves with exercise and improves with NSAIDs, and there is loss of movement in all planes, and there is enthesitis and tender SI joints, and there are other associated problems relating to skin, eye, etc. And family history is positive. Then the referral was supposed to be made to the rheumatologist. However, if the back pain was less than 3 months, onset was acute, morning stiffness was less than 30 minutes, accompanying neurological symptoms, improving with rest, Then they were supposed to refer to the relevant specialities. Again, they were supposed to, in history and examination, identify certain red flags like acute pain onset, fever, unexplained weight loss, incontinence, history of cancer, unilateral back pain or sacroiliac joint pain. Then again, they were supposed to refer to the relevant specialty. So then these were the guidelines given by the Society for Neurology, then the Society for Orthopedics, a Society for Gynecology and Obstetrics. They all gave their own guidelines. Then non-pharmacological pain management was explained, pharmacological interventions were explained, certain drugs were explained, their generic names and doses, etc., side effects were explained. Some interventional procedures for pain management were enumerated, not taught. So outpatient and chronic pain management was explained, inpatient and acute pain management was explained, analgesia and pregnancy was explained, and a roadmap for referrals was given, which said that specialist referral access, specialist referral was to be done after assessing the suspected underlying etiology of low back pain and after determining the appropriate speciality where to refer. And these were the either to refer to the physical therapist or orthopedics or neurosurgery or rheumatology or interventional pain management or to the family physician or to the gynae and obs department. So, ladies and gentlemen, I think this was a very useful step taken by Getz Pharma, and I think we can improve upon it a lot. And I think others should also come forward to make guidelines for many other problems which haven't been tackled as yet. And in the end, I would like to say that Allah always has something for you, a key for every problem, a light for every shadow, a relief from every sorrow, and a great plan for every tomorrow. It is for us to find it. With that, ladies and gentlemen, I thank you for your time and attention.
Thank you, Professor Samina. That was a very informative speech. Our next speaker is Professor Kichul Shin, consultant rheumatologist at Seoul National University, Korea. Today, he will be joining us virtually and sharing his experience and insights in a talk titled Establishing an Electronic Patient Registry, Points from the KOBIO Registry. Please join me in welcoming him to the screen.
As the director of the KOBIO Registry, I would like to share a few points that our team have contemplated and established throughout the past years. So this is disclaimers. KOBIO is funded by the donation of biopharmaceutical companies to the KCR. And here are the key references for today's talk. Especially, I would like to point out the first one, EULAR points to consider when establishing, analyzing, and reporting safety data of biologics registers in rheumatology by Dixon. I would strongly recommend this publication, and there are other similar publication that has been used for this talk. For RA registers in Korea, there have been or ongoing registers currently. And briefly, as in other countries, there's a health insurance database. We have it's called HIRA and NHIS. There's also a Korean National Health and Nutritional Exam Survey, KNHANES. Although the RA information, patient information is limited in this registry. There was a nationwide register called Corona, led by Sang Chol-bae from Hanyang University. The patient registrations was around 2009 to 2011 and followed until 2017. This database was donated to the KCR, and the KCR members are currently using this as well. And for today's talk, the KOBIO has been established in 2013, and I will discuss this more in detail. So today's contents would be establishment for a biologics and targeted therapy registry, and I have devised trying to utilize to simplify by using 3 P's, which are planning, practice, and productivity. This is not a formal acronym or term that is used in the literature. It's just for today's talk. And I will try to summarize my talk in the last slides. So this is the paper that I mentioned by Dixon and others. EULAR points to consider when establish biologic register in rheumatology. This is a very well-written and detailed description for those who would like to thinking about making a registry. This actually was William Dixon's thesis, and it has been encompassing not only the establishment, but also analysis and reporting safety data of biologics registers. Once again, I really recommend for those who are interested in making a registry. So first, for plannings or principles, the most important question would be, what is the primary objective of the registry? So for instance, we would have to define the reasons for establishing the registry and the major scientific questions. And further on, consider sample sizes and duration needed to obtain sufficient information to address the main study questions using power calculations. So is it about efficacy, or is it about effectiveness? Is it about drug survival or retention, adverse events? Or is it about changes in socioeconomic parameters? And there could be others. And as a matter of fact, in some occasions, you could actually fulfill not only one but several points listed in this slide. In the past, the registries for biologics has been driven by the question of its adverse events. That is also, in fact, what was mainly considered in establishing KOBIO registry. The reason for that is actually about funding. We will discuss about later. Funding from pharmaceutical companies is one of the key aspects of running a registry, and for them to be interested in this registry, I think the common interest would be adverse events. So this should be considered be a long-term in a systemic manner because once you establish this, and data collection will go around this primary objective. So points to consider, population to be targeted, what population you'll be registering in this registry, data items to be collected, treatments, and the treated condition. What will be the outcomes? How would you follow up? Data collection process and who would collect the data handling and storage, and ethical and legal considerations. These bullet points are actually it's not just a simple task. It's there has to be multiple aspects within each bullet point to consider, but I just wanted to lay out the key titles or subtitles for this matter. And in linked with this, so I would like to briefly talk about the KOBIO registry. The KOBIO registry is a prospective inception cohort since 2013. At the peak, maximum 40 centers have been involved in this registry, but frankly, it has been reduced for some time. We'll discuss about that later as well. It was spearheaded by the KCR Clinical Research Committee. It took about a year or so to get all the pieces and preparations before launching. Again, the aim of the KOBIO registry was to assess long-term adverse events in biologic users with RA, AS, and PSA. So what this means is the outline of data collection, the format of data collection was actually similar between these three disease entities, and we could use one ECR system and encompass all three these diseases. Once again, the reason why this was possible is at launching, the biologic agents for the three diseases were quite similar. Now it's quite heterogeneous, as a matter of fact. But at that time it was possible, and I think it might be a consideration not only establishing an RA, but also AS and PSA as well. Patients who are initiating or switching to a biologic or JAK inhibitor was the population. Written informed consent was obtained, and this is not a paper, but a web-based electronic CRF system. At that point, RedCab was not popular, for instance, in the early 2010s, so we decided to hire a website design company. So KOBIO registry at its peak, I apologize for this being in Korean. This just depicts how many centers were involved at the beginning, and you can see it was quite spread out nationwide. To also have a web-based system, you would need to consider having a web page. So, of course, this web page was set up a few years later after the launch of the KOBIO registry. There was, of course, a web-based ECR system, so we can link directly by web at launching, but to make things more kind of in order, we also made this web page, and also this would be the gateway for entering the data in the KOBIO. So this web page basically also includes what KOBIO is about, what kind of publications has been in the literature, what other considerations, such as there's also some newsletters that I will show you in the following slides. So it's kind of a multi-purpose website, and normally other websites for web-based registries also have this as well. The following slide, this slide or what it shows is kind of a dashboard image of the initial and follow-up registration forms. For instance, the left dashboard image A is the overview of the initial registration forms. The B is the follow-up registration forms. It's pretty much similar in appearance, but you can see the some parts are different. For instance, the follow-up has the outcome box, and the initial page has a risk factor box. But basically, the other aspects are similar. So this is not, of course, the ECRF in entirety. You can click this, and there's a detailed web page showing the components of each parts listed here. One thing to remind you is that once you launch the registry, it is possible to amend the existing contents, but it's difficult, though not impossible, to add a new item to the electronic CRF. So you have to plan, I think, ahead, and you might have to stick with it, and that could be, of course, a merit, but also a limitation in some aspects. We also included MEDRA. Many registries in rheumatology are using the system. The KOBIO registry adopted the MEDRA term for reporting adverse events right after its launch, and updated to a electronic version in 2019, allowing researchers to easily select preferred items online. This is also was helpful to the research nurses to be acquainted with MEDRA as well. So before going to number 2, I would have to discuss about the funding issue. Funding is the key element for maintaining the registry. This should be based on the situation of each society and country. In general, the funding is based on donations from pharmaceutical companies or grants from numerous sources. The resources for running KOBIO have been dependent upon donations from pharma to KCR and the annual budget of the Committee for Research within KCR. So number 2, let's go into practice. So points to consider to jumpstart the registry. First, there will have to be an IRB approval of participating centers. There should be, this is quite important, a dedicated operating team of members, which includes study manager, data manager, research nurses, if possible, a web manager, administrator, and others. And it's important to motivate not only the researchers or, of course, patients as well, how to compensate. Some registries provides a registration fee to the participating centers. Some registries do not. But this driving force is very important to maintaining the registry. The card on the right bottom in Korean, this was kind of a KOBIO card which was provided to patients who are registered to KOBIO. This listed information includes the name of the biologic or JAK inhibitor, the start date, and information of the center. So this was kind of a minor motivation or something to give to the patients for them to keep in their wallet or purse because some patients are not well aware of even the name of the agents of the biologic or JAK inhibitor. So I think this was a good touch to provide something to provide to the patients registering the KOBIO. So points to consider for maintenance, you need monitoring. This monitoring meaning not only how they are collecting data in the website, but also are the documents well prepared or managed within the site. So we would visit the sites in person in the past. After the COVID, it was quite doing a virtual meeting instead of in person. Workshops for both participating hospitals, but also for the study team. You could think about newsletters, also periodic reports to stakeholders, such for investigators, donators, the KCR, and for patients. For instance, we have a biannual workshop on and offline. This is dedicated to clinical research coordinators and researchers as well. The lectures are workshops include lectures of disease entities, for instance, for research nurses about RA, AS, and PSA, filing in clinical record forms, how to do that, giving example cases, feedbacks, and others, how to capture the adverse events, and how to use meta terms. This is example of the newsletter that we publish every quarter. So we send out these newsletters 4 times a year, and this shows what the entirety of the newsletter is not included in this slide, of course. We have, we show the status of the registration. We actually kind of line up which centers have collected data most, also other announcements and publications as well. So what is also important is working with pharma. So we send out an annual report to pharma. In terms of severe adverse events, of course, pharmaceutical companies will be interested as well. So we devise an instant email report upon recognition. That's kind of the example that's shown. The right side is the example of what we send out to the pharmaceutical companies. We also work with pharma to publish drug survival studies. We also have regular joint discussions regarding KOBIO as well. Lastly, for productivity. So data is utmost important. So data cleansing, mining, analyses, that's, I think, a must. Meeting the primary objective, are we heading to the right direction? How to provide the data to researchers is also a task. Data privacy policy, authorship, and others, and publication has to be activated, or let's say recommended to also the study team, but also to the researchers who are interested in publishing from the data, and also, of course, reaching out to patients and the public. So you would need a well-written manual that defines the eligibility of data users and also outlines the acquisition and discarding of provided data, also describing acknowledgement, and addresses other relevant details. So not only registering, collecting, maintaining, but also the ultimate, of course, is reporting, and publication. Also, other methods are quite have to be you keep in mind for this to be a successful registry. So this was published in 2017 by the study team and one of the researchers in our center, in one of the centers. So this is one of the publications. There have been, of course, numerous other publications throughout the years. I would like to share some hardships facing hardship that we are facing at this point. But this is not only, of course, confined to KOBIO. I think ongoing registries would have this issues. So minimizing dropouts, coping with missing data, study team, personal management, securing ongoing funding is, of course, of importance. Maintaining productivity and awareness, and limitations. Sometimes the scope of the existing data limits the analysis between two existing registries, for instance. But of course, this is not a common thing that has happened. But this just shows how it is important to first define what kind of data or items you'll be accumulating for the registry. So the ongoing quest of KOBIO is to work with the stakeholders and be productive, maintaining the numbers for the registry itself, leading to the goal for giving back to our patients. This is throughout, I think, newsletters, announcements, and also through patient group and KCR workshops. Well, could be other opportunities as well. To summarize, defining the objective is the key step in establishing a biologics and targeted therapy registry. Forming a study team and steering committee to oversee the operation is essential to better manage the registry, and equipping the necessary documents, manuals, and others are also necessary. Securing funding is essential. The ultimate challenge is maintaining the registry. At the end of the day, the registry can only exist by accumulating follow-up data. I'd like to thank KCR and all the stakeholders, and especially Kimi Heinrich for helping establishing and maintaining the KOBIO registry. And I thank you for listening to my presentation till the end. Thank you.
Thank you for that insightful presentation. We now transition into the Q&A portion. We request our chairpersons to moderate the discussion and engage our speakers.
Okay, excellent presentations by our speakers. I have got a question which has been asked by Dr. Saqib Salim. It's a theme which resonates with our normal clinical practice. The question is that in patient with chronic back pain and comorbid depression, what is the hierarchy of therapeutic targets like pain reduction and mood stabilization? Probably they are asking that which one to stress more, and the question is directed to Dr. Professor Samina Ghaznavi, please.
Assalamu alaikum. From what I understand is that you want to know about the depression that the patient might be undergoing. Is that the question? Is that the question?
Yes, the question is that normally we see patients with back pain who are having back pain along with the depression as well, both
Okay.
back pain and depression. So what would be the target of treatment?
Okay, so like I said that these guidelines were only for the local doctors, the GPs, the liners, and they were supposed to identify. And if it was a simple back pain which settles with a little medication, some rest, some physical therapy, then they were supposed to just keep the patient in follow-up. However, if the red flags were picked up, like localizing signs which caused a referral to the relevant specialities, then they were supposed to refer. However, if there is a little degree of anxiety and depression accompanying the back pain, which could be chronic as well, so you might have seen in the guidelines, we did mention low dose anxiolytics, low dose antidepressants for a short period of time. Okay, I hope that clarifies. Thank you.
Thank you, Professor Ghaznavi.
Okay, thank you. So next question is directed towards Professor Shin. The question is from Dr. Ali. He's asking, how can AI systems be integrated into such electronic databases?
Thank you. That's an excellent question. For now, I don't think I could share any expertise regarding that question, but it is definitely the case that AI has become one of the key tools helping us in the clinic, especially in complex cases. So I think it might be helpful in summarizing the data accumulated in the registry. For instance, if you could ask the AI for a brief summary of the current registration, providing a kind of an Excel sheet, I think that could be utilized also when maintaining a registry. Thank you.
Thank you, Professor Shin.
So I think there's a question from Dr. Beanish for Dr. Kallum. It does say, why does diagnosis in rheumatology often remain an enigma? And I do understand that was the topic of our whole discussion, and it has been discussed quite a bit in detail, but if there's anything else you'd like to add.
Yeah. Yeah, rheumatology is a field where, there is no clear-cut ways of diagnosing diseases, and it is the physician's clinical skills that will diagnose most of the diseases, and then the investigation will give some guide as to how you are going to manage the patient. There is no, that is the beauty of the rheumatology. It is always a problem. Most of the diseases are actually complex, and their presentations are very heterogeneous. So, more you see clinical patients, the more you become confident in making a clinical diagnosis. So my advice is actually, rather than just rely on making a definite diagnosis, you have to get the overall clinical context of the patient and see whether you can narrow down your areas where you can actually treat the patient, and then think about the definitive diagnosis later on, but you have to manage the patient, and then during the course of the disease, and it is very important that you should follow up your patients very carefully, and all of a sudden you might have to change the diagnosis. So it is very important that you get a very good clinical history and thorough clinical examination, and there is no substitute for these two skills. That is what I want you to get in your practice actually.
Absolutely. Thank you so much.
I would really like to thank Professor Kichul Shin for joining us virtually. And it's me, Ahmed Saeed here, and we really missed you this time, and we hope to see you soon in Pakistan, and share your experience of setting up such a wonderful registry, which is like generating such a good data from your country, and why not we can have just a replication of what our colleagues have done. This is how rather I say, rather than reinventing the wheel, just go to someone like Kichul, ask him what to do, and he would be there for you. Thank you, Kichul, for joining. Thank you.
Thank you, Ahmed. I'm sorry not for being there in person. Definitely we will be in touch and will gladly help in any way for the PSI registry. Thank you.
Thank you.
Thank you to our speakers and the audience. I would like to request our worthy chairs, Dr. Tahir Mahmood and Dr. Asher Ikhlaq, along with Dr. Aisha Mahmood, co-chair, to present a token of appreciation to our speakers. Dr. Kallum Deshapriya. Dr. Samina Ghaznavi. We would also like to extend our gratitude to Dr. Kichul Shin, who could not join us in person. Now we would like to also request Dr. Sarah Lane Khan to join us to present a token of appreciation to the chairs of the session. Dr. Aisha Mahmood. Dr. Asher Ikhlaq. Dr. Tahir Mahmood.
Thank you. And with that, we conclude this session.